Good afternoon.
Good afternoon, Dr.
Really?
Agrawal.
I've just brought some notes in that Mr. McIntosh asked me to look at.
Yes, so I wanted to check about this 4B, 4C issue. So, now, we'll put the notes to one side for a moment because you looked at them, but we want to just see, are these your own notes prepared in preparation for this?
These are copies of the documents you mentioned earlier.
Right, fantastic.
Yeah.
Well, so
there's one sheet which has my notes relating to that.
Fine. So let's just start back where we left off, which was which ward is which in adult bland. So just to nail things down, we have 4C and 4B. And your report from 21 was about 4C.
Indeed it was.
So what was the patient population being accommodated in 4C?
Thank you, Mr. McIntosh. It's a little annoying when you don't recall the things you've written yourself, so my apologies for that. But 4C, which is the ward I was writing about, and the issues of ventilation, is a hemato-oncology ward and a renal ward, or certainly was at that time, looking after all adults with various hematological diseases having treatment, except patients undergoing bone marrow transplant procedures, and they were on, still are, I believe, on 4B.
So would that be, in fact, a different approach from your unit, where they're all on the same unit?
No, effectively, it's identical, and we have two wards, 5A and 5B. I mean, in our setup, they're physically next to each other. We call 5B the bone marrow transplant unit, but in reality, it's slightly interchangeable.
So, well, let's actually talk about ventilation and your knowledge of that. Just going to take a little note. Yes, the screens haven't come on yet, so I wonder if the feed is working. I wonder if that can just be checked. Normally we see us. Yes, that's helpful. So, thank you, Ms. Crawford. So let's just orientate ourselves. So,
excuse me,
if we approximately, which year were you instructed to start work on the 4C report?
Approximately 2020, possibly 2021, since the report date.
That's helpful. So at that point, what did you understand to be the ventilation standards that were fitted toward 4C?
Well, the requirements were for an SHTM compliant system.
So what would that have been?
So that's basically positive pressure, 10 kilopascals, and 10 air changes.
And would that include HEPA filtration?
Sorry, and HEPA filtration, yes.
And what did you understand was actually in place in that ward?
It was a HEPA filtered system, air changes, did not meet the 10 requirements. I think they were...
Let's look at your report, because I'm not convinced that I'm worried you might be, as it were, misremembering. So your report is in bundle 44, volume 5, starting from page 104 we'll go to. And just looking at it, looking at the executive summary, that doesn't mention what the ventilation standards are. In page 105, it doesn't mention what the ventilation standards are in the ward at the time.
Or you use the word standards, you mean specification?
Specification. If you go to page 106, and over the page 207, can you help us about whether this ward had HEPA filtration as far as you understood it?
Yes, actually, I think I may be wrong there. I haven't mentioned HEPA filtration here. Yes.
Because could it be that the ward, in fact, had no HEPA filtration, 2.5 to 3 air changes per hour,
Yes.
and no pressure differential as per the rest of the hospital?
Yes.
And possibly a small differential between the rooms and the corridor.
Yes.
Right. And so your report is in respect of that ward
Yes.
and the patient cohort you just described.
That's correct.
Right. Let's go and look at 4B. So at the point you were instructed, did you know what the ventilation requirement status of 4B was when you were instructed to do 4C?
Not that I recall, no.
Do you
This
know?
was specifically
So
related
again, you've
to
used the
4C.
word requirements. Is that the word you mean to use?
My lord, you're right to pull me up. In 4B, at the point you were instructed, did you know what the ventilation was actually providing in 4B?
I was not instructed to look at 4B.
I appreciate that, but I'm just checking whether you knew.
Oh, I see. I don't recall that being something I knew about since it wasn't part of my instructions. I don't think so.
Right.
I don't think so.
So let's just step back from this. And from the point of view of writing this report, the HAD report, you're aware that we've looked at text which describes how the patients in 4C arrived in the hospital with everyone else in the summer of 2015 and then stayed, that cohort. So do you know whether the ventilation system was unchanged between 2015 and when you started writing your report on 4C, or whether it changed?
Remedial work had happened, if I recall.
But it was still 2.5 air changes, no HEPA
But they
filtration.
hadn't managed to get it up to specification.
Right.
That was explicitly stated.
Yeah, so it's consistent is what I think we're looking at.
Yes.
Right.
Yes.
So we look at 4B, the adult BMT unit. Now, your report describes how those patients were in the hospital for 5-6 weeks in the summer of 2015. At that point, BMT patients, do you know the ventilation that was actually fitted in Ward 4B at that point?
I don't think I do know.
Right.
I can't recall that information.
When they return from the Beatson, from North, in June 2018, do you know what the ventilation system that was in place that met them effectively?
Yes.
What was it?
It was a HEPA filtered system with approximately 6 changes per hour.
Right.
So 6 changes per minute, and a pressure gradient that was still not meeting 10 kilopascals.
And there was a airlock door at the entrance of the ward.
Yes.
Yes, right. Do you know anything about the ventilation that was in place in the ward they'd been in at the Beatson, the BMT patients?
I was not provided with any information about that. I only know from documentation elsewhere that the Beatson air handling unit performed to a higher standard. That's why I've read, but I've not seen any documentation around it. Yes.
And so when we think about the design of this study, you look at North, South, and adult BMT in 3 categories. So let's look at the ventilation for all 3. What knowledge do you have about the ventilation that the North hematology patients were accommodated in?
I don't.
You don't?
I don't.
Are you effectively making an assumption that it is in compliance with the standard that Ward 4C was not in compliance with?
No, I'm making the assumption it was normal ventilation in a hospital ward, but I don't know that.
What do you mean by normal ventilation in a hospital ward?
Well, assuming that since I don't know the structure of the wards in the North sector or the South sector for that matter, and they were not handling bone marrow transplant patients, so my assumption was they would not be put in HEPA filtered rooms. There wouldn't be a requirement for that. I think so. I assume that wasn't the case, and I would also assume the case they were not in positive pressure rooms.
Why would there not be a requirement for the North sector equivalent? If a requirement, I mean you mean SHTMO301.
Yes, yes.
Why would there not be a requirement on the North sector patients to be in, as it were, the standard that 4C didn't meet?
Well, as I was referring to earlier, the many patients are not managed in an SHTM0301 compliant.
No, I understand
ward.
that.
So
That
my
wasn't
assumption
question.
had been they weren't.
Yeah, so if I understand correctly, the point you were asked to address in this report, the 29-21 report, was, does it matter that the patients in 4C are in a non-SHTMO301 compliant environment?
Yes.
Was that broadly fair?
Yes,
Right.
yes.
Did you make an assumption that the patients in North sector were in an SHTMO301 compliant environment?
Okay, sorry, Mr. McIntosh. I just need to clarify because we're talking about two different reports. The one submitted to this inquiry and
Well, you're right. You're right to do
the
that.
one from 2021.
Well, I'll
So
break it down then, so it's easier. So, when you did the 2021 report,
yes.
the question you were asked, in essence, was, is there an issue arising from the fact that Ward 4C is not in compliant with SHTMO301? That's correct.
Yes.
Right. Putting that to one side and now dealing solely with a new report.
Right.
What was the purpose of looking at the Aspergillus or bloodstream infection rates in these three cohorts of patients? What were you trying to explore?
We were exploring what were the incidence rates of bloodstream infections and infections attributable to Aspergillus in the different sectors covered by the Greater Glasgow Health Board.
So let's imagine, I know you didn't find this, but let's imagine that in the case of the Aspergillus work, you had found an above normal incidence in either Ward 4C or in Ward 4B when it was at the Queen Elizabeth. What I'm putting to you is, would you have needed to know what the other parts of the study were exposed to in order to work out whether that was related to the ventilation?
Well, I would, if I may, just phrase your question
Please.
Slightly differently, because it comes back to the design of what we thought, how we wanted to try and answer the question.
Right.
So we wanted to answer the question by looking at observed rates.
Yes.
If we observed rates that indicated there was an increased rate at Queen Elizabeth University Hospital versus the other sectors, then we would have surmised that there was potentially an issue as compared to the other sectors.
Why?
Because the other sectors, and this is contemporaneous, so the other sectors were treating patients with hematological malignancy, and they were, it's not just a bone marrow transplant individual that's at high risk, it's patients with in particular, patients with acute leukemia undergoing treatments for acute leukemia that are at high risk.
And where would you have expected them to be? In which ward?
Well, in the Queen Elizabeth University Hospital, they would be in 4C or 6A, is my understanding.
Right.
Yeah.
Would the 6A ones have been children?
Well, I think the children moved temporarily to the adult wards, didn't they? So
right. Could it be that 6A accommodated before the children moved to care of the elderly ward and has never accommodated hematology patients? Is that possible?
I don't know.
Right. Okay.
I'm not aware.
So the point I'm putting to you about the design of the study with respect to ventilation is that the patients in the bone marrow treatment ward were first in the Beatson, then they were briefly in a non-HEPA filtered ward in the Queen Elizabeth, and they were back in the Beatson, and then they were in a HEPA filtered ward in the Queen Elizabeth, albeit with not the right air change rate. why would you expect to see? Why would you expect to see any particular signal in that data if they had HEPA filtration effectively for the whole period, apart from the 5 weeks in summer of 2015? Why would you see anything? Why did you look?
Well, I think if I've understood your question correctly, then there's an assumption in there that if you have broadly similar construction, broadly similar specifications, in fact inferior in Queen Elizabeth University Hospital, then you would not necessarily see any differences in infection rates, which is a logical assumption. But that's exactly what we were testing.
So yours was just an open exploration of whether we would see anything.
Absolutely, yes.
So the fact that you have effectively tested a group of patients who, when in the Queen Elizabeth, apart from a very brief period, had HEPA filtration, doesn't prevent your broad exploration being interesting.
No.
No. Okay. Let's just touch on the water for the moment, because we're doing geography, so we might as well do it all in one place. In the BSI study, which of the patients, the adult patients that you looked at the Queen Elizabeth, were exposed to unfiltered water in the Queen Elizabeth?
I don't know the answer to that. We did not attempt to answer that question.
It's just that if we understand the evidence correctly, apart from the 5 weeks in the summer of 2015, none of the adult BMT patients were ever exposed in their own ward. Maybe when they went elsewhere in the hospital was different, but in their own ward, to unfiltered water. And how can you draw conclusions from the absence of a signal in the adult BMT patients about the water if you don't know they weren't exposed to the water?
Can I go back to the letter of instruction?
Yes, of course.
For a second,
So that's
please?
bundle 44, volume 1.
I haven't brought that in with me, so
No, that's fine. We've got it on the screen.
Thank you.
It's on page 234. Would you like the appendix?
No, because it was. If we go to the next page, please.
Yes, of course. Next page, 235.
Part of the information we were given. Oh, sorry. Do you mind going back a page?
Yes,
Because
234.
Yes, I think it's actually in the bottom. The very last sentence on that page. We're told here, it should be noted that the QEUH and RHC have a shared water system, but the individual wards have differing ventilation provision. Hence, we were certainly under the impression that it was the same water, or more or less the same water, being provided to different parts of the hospital.
Because if we go through to page 237, had you read the document in the footnote, the HPS summary,
Yes.
you would have learned that at points during 2018, various interventions were taken, including fitting point of use filters. And whilst there is definitely a debate about whether they were fully effective, that's an intervention which changes the nature of the water that patients are in contact with. And we also know, which isn't in that report, to be fair, that later on, certainly by 2020, the health board become confident, and increasingly confident, that they've managed whatever's in the water, whether it's contamination is the right word or microbial proliferation, whatever the word is, they've managed it. So there's a temporal change in the water experience, but you weren't aware of that.
Can we look at the next page, please?
Yes, of course.
For a second.
Over the page, 238.
And the next page, because I think we're somewhere else now, aren't we?
We're on Professor Hawkey's letter.
My recollection of it, the letter did say that interventions had happened, but I cannot see it.
I think it does, actually. If we it might well be on 235.
Yeah, let me just look at this.
So you'll see at the top of the page, and this is about ventilation, but for completeness, there's a reference at the end of that first paragraph to remedial works to the Ward 4B.
Yes, and in the next paragraph.
And then there's mitigation measures at the bottom half of the second paragraph.
Yes, we're told that point of use filters were used and subsequently installation of a chlorine dioxide system to dose the water with dates there.
So
that information we did have.
Yes. So whilst you don't have the data of the point of use filters in there, should I be in any way concerned that you're looking to see if there is an increased incidence of infections in the case of the adult BMT patients who aren't exposed to unfiltered water, apart from 5 weeks in 2015?
Just to clarify, so it is your point, Mr. McIntosh, that the BMT unit patients, the adult BMT unit patients, were in an environment without filters?
No.
Is that?
It may be quite the opposite.
It's the exact opposite. I think what I should do is take you to the chart, which I discussed this with Dr. Drumwright yesterday.
Yeah.
So it's the same bundle. It's page 93.
Okay.
And we'll just look at the top half of the page. So this is incident of environmentally relevant bacteria within BMT patients only over time. And the blue line is at the Queen Elizabeth.
Yes.
And the red line is at North. Now, ignoring for a moment the 5 weeks in 2015, which I'm not sure that makes it into this data table, the position that we understand it is that for the whole period in the blue line, those patients had all their water sources in their ward filtered at point of use. And that once you get past late 18, as described in that letter, there's now a chlorine dioxide dosing system. And so what I'm concerned about is that in the text that relates to this chart, you say on the previous page, 7.2.6, we are interested in examining single patient populations as services transferred from another hospital to determine if there was an increased number of cases of environmentally relevant bacteremias, which would be indicative of environmental sources of infection. Now, why would transfer of patients into a ward which had filtered water and a system which was about to have chlorine dioxide have any prospect of having an increase in environmentally relevant bacteria? What's the mechanism that would be involved in that?
I go back to the original approach we took. So you're asking me, why did we not, why weren't we aware of these things, which I think we've been over several times now. And our approach was, well, we will look at the data and see if that says anything. And then the question of, well, if it shows something, what does it mean? Was something then we'd come back to.
Because at the end of this paragraph on page 92, you make an observation that the data, that's the chart we looked at, suggests the incidence of bacteremia attributable to environmentally relevant organisms may be occurring at lower rates than the norm for the Greater Glasgow area, although these findings should be interpreted in light of other factors that could influence incidence over time. The other factor being that they're now in a ward with a filtration system, and if I understand other witnesses' evidence correctly, the largest amount of water testing anywhere in the United Kingdom going on. But you didn't know that?
No.
No, okay.
No.
What I want to do then is to return, if I might, to your report from 2021, because whilst I appreciate it was produced in a different context for a different purpose, so that's in volume 5, and if we go to page 105, please. The questions I have relate to the sources of infection you describe on page 109. 109, please. There we are. So 4.1.3, sources of infectious pathogens. You list them. There are 3 here. Patients themselves, airborne pathogens, transmission of pathogens from visitors. And I just want to understand here whether that's a complete list, whether there would be other forms of ventilation-related sources of infection, particularly waterborne material that is in the air because there's been spray or shower or something like that, or fluid-generating procedures.
Yes, so that was raised in various comments to our report. In
Yes.
fact, obviously, I'm not sure this. In fact, this was seen by some of the expert witnesses to the inquiry, and the point was made that there's generation of aerosols. So, in other words, airborne particles from taps, sinks, showers, and hence, if you have a ventilation system, or you don't have a ventilation system, but if you have a ventilation system that's not providing the air changes that it should be providing based on specification, then that would lead to a material increase in, well, that's how I read the criticisms, a material increased risk of infection of those non-normally airborne pathogens.
Yes, so the concept of dilution seemed to be talked about.
Yes, so in the comments made, there was no description. I seem to recall it was Dr. Mumford and Mukherjee's comment, I think.
Yes, it's their commentary.
Yes, so they didn't specify which non-airborne pathogens they felt were most involved by this, because it was unclear to me which pathogens they meant. And they were referring to a previous report by, I believe, I hope I've got this right, Dr. Dempster.
It's a joint report between Dr. Mumford and Ms. Dempster, who was, lead HI infection control nurse for NHS England.
But I did go and look at what was said in that report, and the implication of that report was all environmental organisms would be regarded as being subject to this problem of not being diluted, as the concern is, by not having enough air changes. So in order to try and consider the point being made, I looked at some of the references provided, and also references provided in our documents around infection control issues relating to waterborne, let's say, outbreaks. I couldn't find any evidence that any of those outbreaks had been resolved by addressing ventilation. And these weren't referenced, these statements. So I was slightly struggling to see what the basis of this was. And there's actually a statement in those criticisms that they were less concerned about airborne pathogens and more concerned about non-airborne pathogens becoming an increased risk to individuals because of the rate change not being as desired.
So that it doesn't dilute the air.
Yes.
Right.
And I wasn't able to really see any basis for that. And I certainly didn't find references to support such statements, which I think you would be required in order to be able to comment on it at all.
Can I maybe just take a step backward? Looking at page 109, which I appreciate is your 2021 report, as opposed to the more recent report. And you're making entirely general points at 4.1.3.
Yes.
And airborne pathogens include, and viral, so that's viruses, fungal agents, fungal spores, most notably Aspergillus. Now, my question is, do airborne pathogens, just speaking generally, include, first step, bacteria, airborne?
Well, certainly tuberculosis is the most obvious agent that comes to mind in terms of being an airborne concern. So yes.
Right. So as a matter of generality, the air is a vector for at least some bacterial infection.
Yes.
Now, thinking about water which has been which is in aerosol form.
Yes.
My apologies for not knowing what the verb is. But a water in aerosol form, is that a potential vector for bacterial infection?
Yes, I would agree it's a potential, which is slightly different from saying, but what is that potential?
Right.
I would have difficulty quantifying that.
Now, would you go the distance of saying ventilation has no specialized ventilation, increased air change, pressure having the effect of excluding one area from another, and filtration preventing penetration of the air into the patient's bedroom? Do you say that has no role in reducing such risk as is presented by airborne aerosols?
Of organisms that would otherwise not be airborne, sorry. To clarify. Yes, I do say that. I can see no evidence that that is the case from the references provided. Even those references referring to outbreaks relating to such aerosols being generated from taps and, for example, and shower drains, they were resolved without any recourse to ventilation.
Well, leave aside at the moment the particular article references. Is there any reason in principle why, I mean, if as you accept, potentially pathogenic bacteria may be carried within water in aerosol form and therefore in the air, is there any reason in principle why ventilation might not reduce the risk presented by such airborne microorganisms?
No, I cannot. No, in principle, it could reduce the risk. There are a variety of reasons why I think that probably isn't the case.
Do you want to expand a little on that?
So going back to comments I made pre-lunch, what we know about ventilation systems currently, with the specifications required, is that they do not perform as we think they are. And that there are areas within a ventilated room, there are blind spots. There are areas of current that are not delivering what we hope they're delivering. And so we already know that what we have doesn't perform as we would like to think it is. And the other reason being, I haven't seen any evidence that it would make a material difference. Theoretically, yes. But clinically and practically, I haven't seen that.
Thank you.
I did notice there were no references there, but I went back and looked at Dr. Mumford's report with Ms. Dempster, which is the one I think you looked at. Yes. And so, nervously checking to make sure I've got the right document open on my computer before we go to it. If we go to Bundle 21, Volume 1, I will jump straight into the report by Dr. Mumford and Ms. Dempster at page 136, if I might. And you're correct that in paragraph 9.28 there isn't a reference. But what I wondered was whether the question of whether there is a risk from aerosol liquids remaining in the air is tied up entirely with the size of the droplet. We had some evidence from Mr. Bennett about that, which you may not have looked at.
I have actually.
Oh, right.
So that's that by
Good.
chance.
So did you see how he discussed the Stokes law and the idea that smaller particles remain in the air longer than larger particles?
So in the long list of documents that I received on Tuesday, I did my best to look at as much as I could reasonably look at and digest, of which that was one. And yes, I did see that.
Right. How do you feel about that idea that that's the best way of thinking about the process, that you think about the size of the droplet and what it could contain and the small ones?
Well, I think it's a bit like the whole challenge we have with ventilation and what is good and what isn't good. And that is there is, in fact, a huge degree of complexity in items that may seem ostensibly very simple. You have an aerosol generated by use of a tap or a shower. There are pathogens there. There are all microorganisms there, so they become aerosolized, and so hence there's a potential risk. But then, what is that risk, and how does that translate into clinical practice? It's not so simple to establish.
The question, the way I was thinking about it, and again, I could tell you I'm probably wrong here. Sometimes you look into a room on a bright sunny day and you see dust particles in the air.
Yes.
And there'll be human skin, lots of lovely things in there, almost inevitably. That's the nature of human society.
Yeah.
But in a high air change environment, they will be extracted out and hopefully replaced by air that doesn't contain these sort of things. You'd accept that?
Yes.
So, whilst it may be that I have to press Dr. Mumford on a basis for this when I see her next week, would you accept that there is a point that low air change rates will to some extent fail to extract particles, they may be small ones or light ones, when a high air change plant would extract those particles before they fell on a patient?
Again, can I answer this in a slightly different way from the question, if you don't mind? It rather feels to me we're missing the point here.
Right.
It rather feels like that. So the suggestion is that environmental bacteria can become aerosolized, and hence, if there's a problem with the ventilation system, that risk is real. And when the real concern around environmental bacteria is not there, it's endogenous in patients. The question I think we have to ask ourselves is, even if they're aerosolized, and even if they're not being cleared, how do they then get to cause infection in the patient? And that would be a question of transmission, of how does the pathogen get in its droplet form to the patient. And the idea that they're being breathed in, I don't know, because we're talking about airborne routes of transmission, seems very unlikely. What's much more likely is the water droplets falling on surfaces. Those surfaces then have the organism on there and then transmitted almost certainly by contact.
Yes, because you would accept there is evidence that flushing toilets will put fecal matter into the air unless you put a lid on them or you extract it.
Yes.
Right.
Yes.
So
yes.
I was just looking through Dr. Mumford's chapter, and I really will ask her about this at the end of the week, next week. But I do remember her giving evidence about splashing. And I do know that Mr. Hoffman gave evidence about how larger particles will fall out of the air quite fast. And I suppose in the case that if a large particle or a splash droplet falls onto a surface, contaminates that surface if it's equipment or it's then touched, and transmits, because of the actions that then follow from that, to the patient, that to some degree, the absence of the dilution that would have cleared that particle before it fell, is that not part of the sort of mix of all these different solutions we might apply?
If I was going to, in a sense, I'm the wrong person to ask. I'm not an infection prevention and control expert. However, in trying to answer that question, if I was going to address that problem, my approach would not be to say we need a ventilation system with high levels of air changes. My approach would be we need to cut the route of transmission, and which basically in this context would be hand washing and in particular line care, because the most likely route of transmission to the patient then would be, the pathogen still has to get, the microorganism still has to get inside the patient. And probably in this context, it would be access into the bloodstream via use of a central venous catheter of some nature, central venous access. So that would be the direction I would
a sort of primary protection.
Yes.
Right. Yes. Okay. Well, let's move on. Let's go back toward 4C.
Just before we move on, thinking of prevention of access of pathogen to patient. You had a discussion with Mr. McIntosh in relation to dilution by air change rate. But, and if this is oversimplistic, please tell me, a system which conforms either to HTM 0301 or SHTM 0301 in respect of a neutropenic ward will include, by reason of HEPA filtration and positive pressure from the patient's bedroom, a means, not necessarily a perfect means, but a means of reducing the amount of airborne material that makes physical contact either with the patient or with the patient's immediate environment. I mean,
yes.
Yeah.
Yes.
Thank you.
No, I could spend hours going through your report, but I've read it and we'll keep reading it. And I'm not going to go back to JCIE because we've read it and we've had some evidence.
Yes.
Other people will have to balance it out. But I want to go to methods of management of infection risk. It's paragraph 5.3 on page 115 of volume 44, volume 5. Now you list a series of 115. You list a series of measures that could be taken.
Yes.
And you describe in A, ideally in single rooms, ensuite facilities, which I think, to be fair, 4C does have. Whereas at BART, your twin-bedded bays with a shared bathroom.
Yes.
I felt it was probably a good idea to ask you to discuss your ward at BART a little bit. So we've worked out that 4C had no HEPA filtration, 2.5 to 3 air changes an hour, which is 40 litres a second into each room. Minimal pressure, small pressure differential to the corridor at no HEPA filtration and no pressure to the rest of the hospital. Now, if we think about the part of your unit at BART that accommodates the non-bone marrow treatment, as it's known, patients, what do they have? So
the fifth floor of the King George Fifth Block at St Bartholomew's Hospital is the cancer floor. Wards 5C and 5D are the hemato-oncology wards. That's not to say patients with hematological malignancies are not managed on other wards on the floor because of bed issues. So that's a frequent occurrence, in fact, a constant occurrence. And on 5C, which is the equivalent of 4C as it happens in this context, we have HEPA-filtered rooms with an airlock positive pressure.
An airlock on the room?
Yes. So the positive pressure is from the room into a SAS, effectively. But
what's a SAS?
So an antechamber.
Yes.
Before coming to the rest of the ward, so the corridor.
Yes.
The corridor is not HEPA filtered.
Right.
So the HEPA filtration stops at the level of the patient's room. The positive pressure is pushing air out of the room into the antechamber, and the pressure in the corridor is pushing air into the antechamber, which is then extracted.
So the room pushes the antechamber pushes the outside?
No. The antechamber is the air pushing out of the antechamber.
So it comes in from the room into the antechamber and it goes out?
Yes, because we don't want that air getting into the rest of the ward, because we may need to house patients there who have transmissible airborne infections, such as viruses principally.
Right.
So, but that is not the setup for the whole ward. So some beds on the ward are not HEPA filtered, do not have positive pressure. It's the normal ventilation of the hospital.
What air change rate would they have?
I don't know. I mean, the air change rates in our HEPA filtered rooms is for 10. Sorry, it's the 12 per minute. But for the other rooms, it would just be
12 per hour? Because that'd be quite exciting. 12 minutes.
Yeah, per hour. That'd be slightly windy in there. Yes. But in the rest of the non-HEPA filtered part of the ward is a standard hospital ward of beds, and they are also 2-bedded with shared bathroom facilities.
And would you put neutropenic patients in
that area,
in the bays that aren't HEPA filtered?
We would, and that frequently happens, but we try and avoid it. But it's
why do you try to avoid it?
Because the patient is neutropenic, and we're trying to offer them greater protection, but it's not practically possible frequently. So let me rephrase that slightly. We do not have a policy to say a neutropenic patient cannot be on a bed in 5C that's not HEPA filtered. We don't have anything.
If we think about HDMO 301, the appendix, which I'm going to hope you remember because I'm not sure I can find it at short notice, it does describe, I think, the concept of a neutropenic ward.
Right.
And I know the SHTMO 301 does. I just wonder what you thought those words would mean. I mean, only in the context of haematology and adults, which is your field. So
let me tell you about 5D, because we've only spoken about 5C.
Yes, which is the 4B equivalent.
Yes. So 5D is a 20-bedded ward, which is entirely HEPA filtered. So to get into the ward, you have to go through an airlock.
Yes.
And once you're in the ward,
you have to go through
an airlock.
Yes.
So 2 double doors, of which there's air pressure.
Yes.
Yeah, in between. But once you're in the ward, then the whole ward is HEPA filtered. All the rooms that have positive pressure, there's no antechamber.
Yes.
Because the whole ward is HEPA filtered. And there's one room on the ward that has negative pressure in order to accommodate patients who may
be infectious.
Yes, exactly. Yes.
And so, effectively, what you seem to be telling me is that the differences between the Barts arrangement and the Glasgow arrangement are, in no particular order, in the 4B equivalent, you have a HEPA filtered corridor.
Yes.
And you presumably have a higher air change rate than 4B if it's at 6. But otherwise, it sounds as if you're looking, in your eyes, the same sort of thing.
Yes.
But in 4C, or indeed 5C, The difference is that there are isolation rooms of a sort. They are positive pressure isolation rooms, would they be called? Or
Yes.
yes,
Yes.
the positive pressure isolation rooms. For what proportion of the patients?
There are 14 such rooms.
And how many beds in the bays?
So we have 14 isolation rooms, and the bays have 6 beds.
So
in total. So 3 2-bedded bays.
Yeah, so the majority of the patients in the ward are put in HEPA filtration space.
Yes.
And so this is my question. Let's imagine you went into work on Monday and they said, terribly sorry, Dr. Agrawal, there's a massive electrical fault in Ward 5C. We're going to move the entirety of the 5th floor to another ward where there are bays, no HEPA filtration, 3 air changes an hour, no pressure differential. Are you happy with that? What would be your response?
Well, the first response would be, why do we need to move the patients if that's where they're moving to?
Let's imagine they're going to be drilling really big holes in
I
all
see.
ceilings.
Things are happening. Okay, we need to move the patients.
Yeah.
It quite obviously has to be a practical response to this.
Yes, of course.
So the patients have to be put in a place of safety somewhere. Would I be worried about the infection risk, which is, I think, where we're coming
Absolutely,
to?
yeah.
And the answer to that is no, because we already manage patients on the 6th floor because of space issues, where there is no HEPA filtration and there is no positive pressure in the way that's being described. It's routine to manage patients undergoing autologous, that's not the same as allogeneic,
yes,
but autologous hematopoietic stem cell transplants or bone marrow transplants in a ward environment without.
And so what's the primary mechanism by which you manage infection risks on the patients on the 6th floor, and indeed on the bays as well? What's your primary protection mechanism?
It's hand hygiene.
Yes.
It's wearing masks, and it's clinical. It's routine clinical care, both from the nursing staff and the medical staff, at least once a day.
Do you have any feel there's a role for prophylactic antimicrobials as part of the protection?
Absolutely, and we have extensive policies on prophylaxis, which basically, in the context of this inquiry, is we do not use antibiotic prophylaxis in our inpatient population at all. So there is no category of patient now. We will give ciprofloxacin or a similar drug for prophylaxis.
So they receive no prophylaxis at all?
Antibiotic prophylaxis.
Right, but they will receive antifungal prophylaxis.
They may receive antifungal prophylaxis, they may receive antiviral prophylaxis, but it depends on the nature of the underlying disease and the nature of their treatment. But we do not use antibiotic prophylaxis in any inpatient, except for exceptional circumstances.
Now, I'm guessing that ties in with what you told us this morning about your particular interest and concern about the growth of antibiotic resistance by reason of antibiotic use.
Yes. Can I just, that's correct, Lord Brodie. Can I elaborate on that point?
Yes.
It's not just my concern. So
I wasn't intending to suggest it was in any way idiosyncratic.
But the point I wanted to make, that as a hemato-oncologist, I have a particular interest in this area, whereas I would suggest the majority of my microbiology infectious disease colleagues already think it may not be a good idea to give prophylaxis, but it is still given to many, as standard in many units around the country and around the world for that matter.
Just to check a medical fact, as it were, am I right in thinking that some individuals are less tolerant of particular antibiotics than others?
Yes.
And am I right in thinking that there are adverse side effects associated with certain antibiotics?
But I think it'd be fair to say that adverse side effects associated with all medicines, including
it
all
occurred to me as I was
antibiotics.
asking the question, that's probably true.
Yeah.
But that's true of antibiotics.
Absolutely, yes. In fact, the concern goes beyond side effects of the antibiotics. The concern extends to masking infection. And I would actually say that's a principal concern, is the inability to diagnose infection that's present because we've used medicines to try and prevent that infection that have not worked.
Now,
so the reason is very simple. If you're going to use good antibiotics, such as the class is called fluoroquinolones, so generally ciprofloxacin, levofloxacin, you can use other drugs to prevent a problem, then you're very unlikely to be able to detect any infection that's present in blood cultures. So blood culture positivity rate decreases dramatically in those circumstances. Does not mean the patient doesn't have an infection, but it means you cannot detect it. Why do we think the patient has an infection? Because they've developed a fever when they're neutropenic, which is a daily occurrence in every single unit around the world. So febrile neutropenia is a normal occurrence. How you manage that has a profound impact, not just on patient outcomes, but also the microbiology of the unit, which is one of the issues for the inquiry.
I think I'm gonna make a fool of myself now. I'm gonna have a go. If I understand what your evident position is that most units, potentially including 4C, would have made a practice of widely prescribing prophylactic antimicrobials.
Yes.
And that had been the general practice, and it may still be practiced quite a lot of the country. Have I got that right?
Yes.
Your unit, in part because of your work dealing with antibiotic resistance, has developed, oh, by the way, there is a transcriber. So when you nod sagely, and I think you agree with me, you have to say yes, otherwise the transcriber doesn't get it. But your unit, partly in response of your desire to reduce antibiotic resistance, has a more sophisticated policy where you choose what to do based on the risk. Would that be a fair way of putting it?
It would be a fair way of putting it. And I would also say it's based on an awful lot of evidence, that's to say published evidence, and it's based on multiple international guidelines recommending that approach.
So when you have a patient for whom the risk justifies the prescription of antimicrobials of any sort, you would prescribe them?
Yes.
Right.
And we do.
And you do?
Yeah.
And am I right in thinking that if you had a patient for whom the risk would justify prescribing such a medication, but they can't tolerate it, you would have the option of moving them into one of those isolation rooms, or even up to 5D. Is that a possibility?
No, I think we're...
Am I talking apples and oranges here?
Yes.
Right, well, can you help me break this down? Because obviously I understand as a non-medical person that a blanket policy has the advantage of covering everybody.
Yes.
And I had planned to ask you a terribly clever question about what would happen if you have a blanket policy and you can't prescribe somebody.
Oh, I see, yes.
And I might still ask that. But if you're operating a more sophisticated policy of risk management, is there ever a scenario in your ward where the risk indicates the appropriateness of prescribing some antimicrobial of some sort, and yet for other reasons to do with the patient's conditions, you can't actually prescribe it?
Yes.
Well, what do you do then to manage any risks that was the risk that was prompting the original decision?
So just to be clear about this, we're talking about prevention as opposed to treatment.
Yeah, absolutely prevention.
Yes. Okay. So probably the best example, given that we do not use antibiotic prophylaxis. So
Right.
that's not a good example now.
Even if you think, ooh, this person's at risk, I'm going to specifically use it for them, you wouldn't do that.
But the whole patient population is at risk.
Right.
And the patients, particularly the focus of this inquiry, are at high risk. They are all at high risk. But the management is. Let me try and describe to you the scenario of what happens with the policy at 4C, which is, having seen some of the febrile neutropenia policies, is to give ciprofloxacin prophylaxis to this patient population. The consequence of that is these patients will all develop fever. So the problem is actually got nothing to do with microbes. It's to do with clinical management. The patient develops fever because we've given them drugs to render them neutropenic, damage the gut, so they develop mucositis, they have central lines inserted, and those they develop terrible mouths, which were inflamed. So there is leakage of microbes into the bloodstream from the gastrointestinal tract. So that's all well documented. These individuals become febrile. They've just had chemotherapy. They are neutropenic or they're about to become neutropenic. So we do what is well established to protect people from life-threatening infection and give antibiotics.
So that's the current 4C, or the current when you wrote the report, 4C
But the
policy.
problem with that approach, and there is a problem, is that you've already given the individual a very good antibiotic and it hasn't done what it was supposed to do.
So your approach is to wait until the problem emerges and then treat it targetedly.
Yes.
Right, I misunderstood, so now I understand. Right, okay. So your approach in your unit is to some extent reactive, but it's done in the knowledge that the reaction will be more effective.
Yes.
Right.
Absolutely.
So we go back to the Glasgow policy. When you wrote this report, they were operating a policy of prophylactic antimicrobials.
I believe so, yes.
Yeah. Would that system work for the patients who can't receive that prophylactic antimicrobial? In a sense, what I'm saying is either you have to be in a complete Glasgow system where everyone gets it, or in a very sophisticated system like yours, you can't mix the two.
Yes. I should just comment, it's very nice of you, Mr. McIntosh, to call out the system very sophisticated. I'm not sure.
You'd always be careful about counsel.
That's very kind of you. I'll take the compliment. I'm not sure how sophisticated it is. If you're a patient in a situation where the rest of the patients are all getting a prophylactic drug, and you're not because of intolerance or basically allergy, most likely, then what should happen? Well, you can use an alternative drug if you want to give prophylaxis. I mean, there are other options. The drugs we've mentioned are not the only ones. I assume, I can't remember this, that the colleagues in Glasgow will have something written in their policy, say what should happen to a patient who is allergic to a prophylactic drug.
So the final question on this topic is this a realistic scenario, which I'm about to put to you? You have a patient or patients who will not tolerate the particular antimicrobial that's involved, and they don't end up with any, perhaps because of their intolerance, and they end up in a non-HEPA filtered space. Should we be in any way concerned that, in sense, neither policy, that is HEPA filtration or antimicrobials, has been made available to them, and they have fallen between those two stools? Is that something we should be concerned about?
It's something we should be mindful of. The word concerned, I'm not sure I would use, because clinically I would still manage the individual in the same way, accepting that they can't have the prophylactic drug that we would have liked to have given them because they're allergic to it, for example. The HEPA filtration issue is really a specific issue, in my opinion, relating to airborne pathogens, and in that context, for this patient population, specifically mold infections, of which by far and away the most important is Aspergillus.
But if you have patients who can't receive antifungals, and they're placed in non-HEPA filtered
Yes.
spaces.
Yeah.
I'm again back to risk. Is that a risk that needs to be addressed? How would you address it?
Well, in fact, in both reports, my previous report and this one, the mitigation of that risk is extensively discussed. And the mitigation of that risk includes, so you can't use an antifungal drug because the patient's allergic to it. I'd have to come back to the fact that there are several alternatives that you can use, so there may be alternatives. It's come back to the importance of clinical care. I mean, you really can't underestimate that, because that is how we alert ourselves to there being a problem or there isn't. So that includes observations done by the nursing staff, it's the information the patient tells us, and it's the daily ward round examining the patient.
Because that gives you the ability to react.
Yes.
Right.
Yes. And in the context of fungal infection, we have blood tests that allow for rapid assessment of could the patient have a fungal infection, which is a bit different from bacterial infections where we have blood culture, but that's always reactive.
Because it takes a bit of time.
Yes, you can use the test for fungal infection as screening if you wish to.
I'm going to propose to move on now. This is the same document we have on the screen, but now page 116. You referred in your report from 2021 to various data about infection risks, infection results. It's paragraph 5.5, and you make a comparison between data you've been given for Ward 4C from 2016 to 2020 and a slightly longer period, slightly shorter period at Barts.
Yes.
What I was particularly intrigued about this was the extent to which you. Why did you refer to Pseudomonas?
Oh, only because I think this was. I'm again doing this from memory now. I think these were all results from respiratory samples. So this was Pseudomonas in sputum samples.
So what I'm intrigued by is why would Pseudomonas, which is an environmentally potentially environmentally relevant microorganism, be relevant to ventilation? Given you've just given evidence that it's not relevant. I
don't think it is relevant to ventilation at all.
So why is it in the report?
It's in the report because there were sputa with Pseudomonas positivity.
So how would the patient have acquired, that's a stupid question because you don't know, what are the potential paths by which a patient would acquire Pseudomonas in their sputum?
If you don't mind, Mr. McIntosh, I just suggest you save that one, Professor Hawkey, because what I don't want to do is tell the inquiry something which may be wrong.
I know, but the problem the reason I'm pressing you is because in this report, and I recognise it's in a different context, you draw a distinction between the infections that are recorded in 4C and the infections that are recorded in your unit. And whilst I appreciate that Aspergillus might well be relevant, and I suppose norovirus might be relevant to ventilation as well, do you see the number of gram-negative infections and Pseudomonas infections relevant to the quality of the ventilation in a ward? Because if you do, aren't you not agreeing with Dr. Mumford?
No, I don't.
Right. So it probably shouldn't be here, is what you're saying.
I do say in the second sentence, in an analysis limited to bloodstream infections. So, because that was the data available. So if the comparison is more to do with the point I was trying to get across was the documented infections on 4C, at least numerically in absolute numbers, seem to be very low.
Right. Based on the information you had at the time.
Yes.
Right. I think the final topic to mention with you is discusses the issue of thermal wheels in ventilation. Now, we've discussed air changes. I think to the sufficiency, you seem to recognise the role of HEPA filtration in preventing particles arriving. So, what view do you take of the use of thermal wheels in ventilation system in a ward like 4C?
I'm afraid I don't have the knowledge to comment on that question. I simply can't answer that.
Well, do you know what a thermal wheel is? I mean,
I only know
would be
from
excused if you
reading
didn't.
material in
Well, if
relation
you
to
don't,
this
that's absolutely fine.
inquiry. So
I have one document I need to show to you, which is an S-bar from, I think, 2018. Bundle 4, it's not on the list, so Bundle 4, page 156. So this is an S-bar from July 2019, prepared by the then lead infection control doctor. You've not seen this, I think.
No, I don't think so.
That was really the question. You wrote a report about Ward 4C.
Yes.
And you hadn't been shown the S-bar.
I don't recall seeing this.
Is an S-bar a term of art in England as well as Scotland?
I actually don't know the answer to that. They've only come across S-bars in the context
inquiry
of this inquiry.
Right. But it seems to be it states a situation, a background assessment and recommendations, a single page document. And you'll see that ultimately, for reasons she's given evidence, Dr. Inkster recommends an upgrade in the ventilation towards 4C. It's in the final box.
Yes. Yeah.
And even, would you accept that there's a slight similarity? No, that's not even a fair point. But you accept she's suggesting there should be some upgrades, but you didn't see this?
I hadn't seen that.
No.
No.
Okay.
But, yes.
And just again, I know you haven't seen it because we asked you about it in one of the questionnaires. You hadn't seen the Innovative Design Solutions report into the ventilation in Ward 2A and 2B either. And we've done, I think, quite successfully, at least we've asked lots of questions and got lots of answers, about you not knowing the facts on the ground at the time. So I'm not going to revisit that. What I want to do now is to look briefly at one aspect of the BSI for results in Chapter 7, simply because we've already looked at the other one, which was the adult VMT results, which we briefly looked at. And so we're in Bundle 1, and we're in Volume 1, rather, not Bundle 1. And we're on page 73. So I went through this with Dr. Drumright, and I can't now remember whether it was in the morning or the afternoon. This is the section entitled Bacteremia in Adult Patients, 7.2.3, in GDC January 2013 to June 2023, with potential environmental relevance. And then the bottom of the page, there's a discussion of what we're to see on Figure 5, noting some spikes. At the bottom of the page, an adjustment for unrealistically small denominators. And then over the page, having carried out that adjustment, there's a discussion of what's then seen in Figure 6. Now, I want to just check in. I've had evidence from Dr. Drumright about the merits and demerits of adjusting for unreasonably small denominators. Is that something you'd want to add your words to, or are you happy to leave to have it?
No, I think I'd best leave that to Dr. Drumright.
Yes. Now, this page at the top, however, the paragraph sentence I'm going to look at is actually looking at Figure 6. So we'll look at Figure 6, which is on page 75. And I think there are two spikes, one in blue, which is the Queen Elizabeth, and one in red, which is at, by that point, entirely the north. If we go back to page 74, the middle of the second line, with a single possible true spike in incident at Queen Elizabeth in early 2018, followed by a significantly lower incident for the remainder of the time period. Now, what I want to put to you is some information that we have about the events that are happening at that time. So, early 2018 is the point when the water incident happens, awareness suddenly grows, and we have minutes of water technical group meetings discussing the discovery of contamination that they describe as widespread. And then we have the interventions we've already discussed. I appreciate you've not looked at all the context in epidemiological terms, and you're not an epidemiologist. So really what I'm asking is, if you look at page 75 and that blue spike in the middle and the lower period afterwards that's described, should we be looking into this amongst the adult hematology patients? Should we be asking ourselves what's going on here? Or is just a spike, but you describe it as a true spike? Should we be looking into it?
I actually don't feel I can answer that objectively. I would really need to consult with both Professor Hawkey and Dr. Drumwright as to what that figure is telling us. So the term true spike means there appears to be a real increase at that time point. If this time point is a year, I can't tell if it's a month or a year, actually. Haven't quite decided.
Well, you described it as early 2018, but I'm, again, slightly suspicious that it might be late 2017 based on the table, but the text says early 2018.
So in that context, it would be, the first thing to do would be to look at which organisms are we referring to. Is there a pattern? And I can't remember.
So let's just think of the steps, because I think it's important that we just think of the steps rather than reaching conclusion. We've had Dr. Drumwright talk about scenarios and counterfactuals, and she's given us some thoughts on that subject. Would we talk to Professor Hawkey about organisms and that sort of stuff? That would be where we would go.
I think so, depending on the question.
But you don't feel able to add to that topic conversation?
I don't think so, no.
Okay, thank you. I might just take a moment just to check that we're about to get to a topic change. Well, I think what I'll do now is I'll move on to the topic of Aspergillus and chapter 8. And then I'll come back to the final charts that were produced by the three of you after that. So if we go to chapter 8, which is on page 123. Now, why did you carry out an examination of rates of infections for Aspergillus in this hospital?
Yes, I think that's partly addressed in chapter 6, if I recall.
Yes.
And when considering the impact of ventilation, I would still insist that the most relevant outputs of that would be airborne pathogens.
And Aspergillus would be the most common.
So as we've just discussed, I mean, particularly mold infections, the spores, so fungal spores, and principally epidemiologically, numerically, that's Aspergillus in this patient population. There are other mold infections that occur, but numerically it's Aspergillus.
I mean, it is the fact that it's numerically the biggest of this group, but in a small field, the reason you pick it, because then there might be a chance of doing something with the numbers.
Yes.
And so to take, for example, Cryptococcus neoformans, you couldn't do it for that, could you?
No, I mean, it would just be too difficult. I mean, I don't see, it's such a infrequent organism to find. In this patient population, it's not that it doesn't happen, but it's really very rare. Aspergillus is as I know the inquiry's already heard, is a environmental, ubiquitous organism. You know, we're all breathing it in here at this point in time. It is quite literally everywhere. Hence, the risk of this to this patient population in particular.
So having decided to carry out this exercise, you weren't, of course, supplied with a nice spreadsheet of results, were you?
No, once again, the question was, well, how are we going to attempt to answer the question of were there increased rates of infection in the Queen Elizabeth University hospitals, including Royal Hospital for Children? And so we again took the same approach, which was to ask the Glasgow Health Board to provide us with as much data as they could, including retrospectively going back to before the hospital was built, so in other words, other sites, in order to try and establish an answer to the question. So that it's in principle the same approach.
But it actually involved you making some actual clinical assessment.
Yes.
Yes. And so that's different from what effectively was going on with the bloodstream infections.
Absolutely, because the bloodstream infections, if you have a positive blood culture, then you have a positive. With Aspergillus infections, and in fact mold infections in general, it's really quite complicated. It just, to say a patient had invasive aspergillosis is unfortunately not simple.
Because it's not just a blood test.
Well, principally because to define that the patient has had invasive aspergillosis, you need to biopsy a lesion which contains the hyphae of Aspergillus growing into tissue, or you have to culture the organism from sterile material. So, for example, that might be from cerebrospinal fluid in an individual who's got central nervous system involved.
You would have a series of different tests, and you'd have data for those tests.
Yes.
Did you also use imaging data?
So the challenge with imaging, and there are many challenges with imaging. So one approach would have, so let me just go backwards. It is in the report, but perhaps it'd be useful for the inquiry if I just quickly summarize it. There are really three arms to accepted international criteria for classifying invasive fungal infections, in this case aspergillosis. The first one is the patient at risk? And by definition, all of this patient population is at risk. So we tick that one, that's easy. The second is microbiological data. Do we have any data to say this could be Aspergillus? And now that data can come from histology, it can come from culture.
Histology, for the uninitiated, is?
A biopsy of a tissue somewhere.
Right.
Since these lesions are airborne, since the pathogen's airborne, it's the airways and specifically the lung that are the main sites of infection. Taking a biopsy from a neutropenic, unwell, thrombocytopenic individual is usually not an option.
Yes.
So it's not available to us. Culture of sterile material is rare. So that happens rarely. In fact, my experience, the only time you're going to culture this organism is from a brain abscess.
Right.
Otherwise, it's not going to happen. And so that leaves us with other microbiological data, which is sputum, what's called bronchoalveolar lavage fluid. So if the patient's well enough to have their lungs examined and washed, then that's a very useful material. And the third thing is blood tests. So that's where fungal infection is slightly different from bacterial. We do have a number of blood tests that can guide us. And so we asked the Glasgow Health Board to provide us all the data that they had.
For all those things?
Yes, for those things, yes. Imaging, the third branch, is complex. And the reason it's complex is because these individuals have imaging done very frequently for many different reasons. So the prospect of trying to go through all of their imaging would have been a not insignificant task.
So did you select in some way?
So the only, yes, I did select, but what I selected was those cases that didn't meet criteria, but if they had suggestive imaging, I would have preferred to count them as cases rather than not count them as cases.
So in a sense, you've got the ones from the various tests.
Yes.
And you add to that
Yes.
some that don't have the tests, but where the imaging is suggestive.
Yes. So let me just be really specific about this. The criteria I used would not be accepted by the international criteria.
So it's not comparable with the international criteria?
No, so I was using much less stringent criteria, and by doing that, I would almost certainly inflate the number of cases. And that was very deliberate because I did not want to underestimate. I'd rather err on the side of having a few more cases perhaps rather than a few less, given it's so difficult in the first place to decide if a case is a positive or a negative.
So how do you? Obviously, this must have taken a significant amount of time.
It took some time. Yes.
Can you give us a feel for when you started doing it?
When did I start? Without looking at my records, I'm really struggling.
Are we talking months or weeks or days or hours? I mean,
it probably took me a few. Well, I mean, the initial tidying up of the data in order to get it into a format that I could then use was a few weeks, and then I spent a fair bit of time joining up all the dots, so to speak.
Yes.
Yeah, so it's a rather manual exercise.
The reason I mention that is because whilst it doesn't, I don't wish to minimise Dr. Drumright. To some extent, she takes a big spreadsheet, she puts it in a software package, and it spits out some numbers. I mean, it's a lot more complicated than that.
Yes.
But it's a relatively quick process in comparison. Just checking that.
I don't know if Dr. Drumright would agree with that.
I'm not sure she wouldn't,
but I would agree with that.
You would agree with that. Excellent. Now, what I want to do is ask you to comment on the NSS response to your document. Now, the reason that they did two responses, and it's the second one that I want to put to you. It's in, unless I've got confused, it's in Bundle 44, Volume 3, and it's on page 222. Because we can read your response to the first report,
right,
in your NHAD response. We read that, and this one is a response to Ms. Cairns seeing your actual data sets.
Yes,
because they didn't quite didn't quite match. Have you read this document?
I have.
You have, right. If we pass delicately over the executive summary and we go to the review of data, page 225. The first issue that she raises is on paragraph 6 of page 226 about deduplication. Now, before we go any further, I think I have to put something to you that Dr. Drumright and I might have inadvertently said yesterday. I don't think NSS is suggesting a 14-day deduplication exercise, which is, I think, what I ended up putting to Dr. Drumright yesterday.
Okay. Yes.
But what they are, I think, suggesting is a deduplication exercise.
Yes.
So, given the length of the incubation period, I suppose varies quite a lot. What's the appropriate way to deduplicate, and why do you not specify a time parameter in your process?
I'm just struggling a little bit with the best way to phrase this, because it's actually it's a slightly nonsensical question in the context of mold infection.
Right.
It's not how mold infection works. It's not how the treatment of mold infection works. So, the analogy with bloodstream infections, where a bacterium gets into the bloodstream, leads to infection detected in the blood culture, treated with antibiotics, and it clears and the patient gets better. Principally due to antibiotic treatment and with the help of neutrophils if the patient's neutrophil count recovers. If there's a second episode at a defined period after that, then that's regarded as a new infection.
Right. Because the first infection would have been cleared.
Exactly. Yes. Now, so if you go backwards here, so the first thing, as I've just told you, it's incredibly challenging to actually establish a case as a case. And then once you've decided it is a case and the patient's treated for it, and hopefully they get better, then they will get better in the context of their treatment and recovery of their neutrophils.
But they'll still have it in their body.
That does not mean, yes, exactly, that does not mean there is no infection. So it's very, very different from bacterial infection, and that manifests itself by typically this patient population is having cyclical courses of chemotherapy, for example. So the next cycle of chemotherapy, patient suffers all the toxicity of the treatments, becomes neutropenic, and hence there's a risk of that pre-existing infection causing a problem.
Because it comes back.
Because it never completely left. So then trying to say there should be a 14-day, 28-day window becomes slightly nonsensical. The only way I can, this is for mold infection.
Yeah.
It's different for candida bloodstream infections.
Sure.
So the only way I can sort of rationalize this is to say, in an individual who had an infection, was treated, they got better, their immune system recovered, and they were well for a period of time that's quite hard to define. So there is no accepted duration of treatment for invasive aspergillosis. So the typical statements are made are from 6 to 12 weeks of treatment. But that isn't actually based on any data.
So can you deduplicate at all?
No, I don't think you can. I think you'd have to have... so there were one or two individuals in the data set who had positivity over multiple positives over a series of months. And some individuals had multiple positives over a period of approximately 1 month. So the key, it's very difficult to say that any of those represent new infections.
So effectively, did you exclude the ones in the 1 month and keep the long ones, or just include everybody?
No, I looked at evidence around hospital admissions if an individual had not left the hospital, then this was all the same episode.
Right.
And and unfortunately, it may well be possible that the individual died. I didn't have that data,
yes.
So I don't know. And so what we're looking at are the consequences of unresolved infection.
So you took that as one incident?
Yes. These are not repeatedly new infections, no.
But the definition there is a bit soft.
My definition?
Yeah, your definition, the one you used, or is it with simply
deduplication? No, that's why the point I'm trying to make. This is a nonsensical concept for invasive aspergillosis.
But your deduplication method that you ultimately chose was the one admission, one infection method.
Yes.
So if they came back and they got aspergillosis again, that was 2 infections.
I'm afraid it's not that simple.
Because sometimes you had them, you took that as the same infection.
Yes. It depends on what was happening in between.
So we just have to accept, to some degree,
yes,
that these numbers contain this judgment by you.
Yes.
Right.
Yes.
And you think that's because of the inherent nature of aspergillosis?
Absolutely.
Right.
Yes.
Now, if you look on page 227, I wondered if you have an opportunity to consider this challenge about the PCR test used. Do you understand the criticism there?
Yes, I do.
So what's your response to it?
So firstly, my apologies to the inquiry and to Dr. Cairns in that I didn't put every single methodological detail in the original report, for which I apologise. I thought I'd been very detailed about classification of cases, and I had been quite detailed. Then when I got into the actual nitty-gritty of looking at the data, that spreadsheet was not provided to the Excel data file, was not provided to the inquiry when we submitted our report, but it was provided subsequently on when questions were returned.
It's the one that Dr. Cairns has responded to.
Yes, but it's all in there.
Right.
So in there, I've annotated each apparent outlier, each case where there is a positive, as in the case Ms. Cairns is highlighting, but it wasn't considered. And that's to do with the fact you can have a PCR positive result, apparently, that at a CT level, so CT represents the number of cycles to get to positivity. So if the test becomes positive at a low number of cycles, that's telling you have a strong positive. And if it takes a lot of work to get to the positive, it tells you have a very low level of detection.
And so you had a threshold in there?
Yes, and at that level of detection, it's not always easy to know, is the test picking up water or is it picking up a pathogen?
And so the effect of this is a bit like the use of imaging, and that you will end up with slightly more cases than you meant to.
Yes.
Right.
Yeah, so what I didn't accept were cases that really had no evidence that there could have been aspergillus infection. So I thought it was reasonable to say, I can't start accepting everything that has no evidence.
But when she first saw this, she wouldn't be able to see this.
Not initially, but on the...
Yes, I mean, that's just a general point, is you didn't include in your report, in appendix, data tables and...
No, so that was...
Any particular reason why?
Absolutely none. I think it was just an omission.
Right.
I'm afraid.
You wouldn't count it as misleading us?
I'm not sure why I'd wish to do that. And I wasn't.
We go on to section 9. I think this is the clinical review of imaging issue.
Oh, yes.
Which we've already discussed. So, to what extent is this use of imaging an essential part of effectively doing what you did?
So again, it may well not be easy to understand. I mean, I genuinely mean it's a slightly complex area. We have lots of different tests, and you know, what do they mean? So this refers specifically to those individuals whose only positive test was something called a beta-D-glucan.
Yes.
And a beta-D-glucan is an indication of a fungal infection. However, it's not an indication of aspergillus infection. And as per all international guidance, that by itself cannot be regarded as an invasive aspergillosis. In fact, there's no evidence the patient has aspergillus, much more likely to be candida, if anything.
Yes.
However, if those individuals had imaging suggestive of fungal infection, then I would have had two elements to indicate, even though I can't say it's aspergillus, if there's a lesion on the chest that looks fungal and the beta-D-glucan is positive, I would have accepted it as a case.
So you effectively put it in?
Yes, but there were no positive imaging in relation to these isolated beta-D-glucans.
Okay. Yes. The only other point is paragraph 10, which seems to amount that you've missed a case out in 2014. Is that roughly what is being said?
Yes, I looked at that and I couldn't agree with Ms. Cairns on that. No.
You think you haven't missed one out?
No, I don't think I've missed
Any
one.
particular reason?
It would be helpful if I had my notes, because I made a note of it in our reply.
But it's in the paediatric data set in 2014 at York Hill.
No, I went back to look at that individual case. I could not find the positive result she was referring to.
Okay. So what I want to do now is to put aside Ms. Cairns's note and actually go back to chapter 8 itself.
Yep.
And to try and understand some of what is in the chapter, and then step forward, look at Dr. Drumwright's work, and then return before we finish to the BSIs and the concept of risk. So if we can go to chapter 8, which starts on page 123 of bundle 44, volume 1. And I'll take this relatively quickly because I think I need to jump to the conclusions. Page 125, you plotted out the numbers of cases you identified across the 3 cohorts. And so orange, those patients are in the Beatson in North sector the entire time.
Yes.
And they have the amount they have on chart on figure 23 on page 125. Yes. And then blue, they're in ward 24, Southern General. We know that, you don't. But they're in Southern General until the move in 15. And then they're in ward 4C through to the end. And then green are in Beatson ward B8, I think. I may be wrong, but certainly the Beatson. Until the move, they go back to the Beatson, and then they come to ward 4B in 2018. And that's the green. And you've plotted that at the top.
Yes.
You didn't calculate a rate for this population. Is there any particular reason why you didn't?
Yes. Firstly, I would have needed Dr. Drumlight's expertise in doing that. It sounds simple enough, but I didn't feel I wanted to be handling that sort of data set for a huge Excel spreadsheet. That's one thing. Secondly, looking back at my previous report,
yes,
I had commented on the very low rates of infection, and I'd attempted to make a comparison of population served,
yes,
as opposed to infection rates, and making the point that there appear to be very low rates of infection on 4C.
Yes,
in that report. I should have at least added some form of comparator here, which I didn't, of that nature. The reason I didn't think about calculating rates is because the observed number of cases, despite my attempt to be very permissive in classification, is very low. From my clinical experience, given the size of the population covered, these are very low numbers of absolute numbers of infections.
And if we look at Adult South, which is blue, from 2017, it's 1 case a year.
Yes, I mean, so I was struck by this data in the manner I've just said.
Yes. Well, if we looked at the pediatric data,
yes,
which is a few pages on page 128, figure 124, it's much 128, please. You've plotted, again, the columns by numbers, and this time you've helpfully provided a translocation diagram of where the wards are at the top. You do seem to indicate there's something different. If you look at the bottom of the page, you're referring to table 19, but it's the same data as on the chart. What is it you noted in the terms of the numbers?
So looking at this, I found it. So again, this is just absolute numbers, not rates.
Yeah.
So it is. I realise now an error should have asked for rates at the very start. I think that would have been helpful, but obviously that came a little bit later. I mean, what I'm struck by here is overall the numbers remain very low. It's the same population being served in the sense of the total population covered by the Glasgow Health Board is still 5.5 million.
Well, it isn't. This is a national centre.
Right, yes. It is.
And the other one isn't a national centre. The other is a regional centre. The adults is regional. This is national.
Oh, I see. Okay.
Yeah.
I haven't picked up on that difference. The point being, I haven't calculated a rate for this. I'm really struggling with my glasses here.
I mean, Dr. Drumright eventually does.
Yes. So I felt that there is not any indication of rates going up and down based on the paediatric population being on wards 2A and 2B, which seemed to be the key issue.
Because the reason that when I look at the top of that table, figure 24, is I don't know whether you know the ventilation arrangements in 2A and 2B and in 6A and 2A and 2B in that transition of time. Do you know what was going on with ventilation?
Sorry, when you say transitional time, you're
So
referring
between 10th of June 15 and 26th of September 18,
yes.
do you know what the ventilation was in 2A
Let me just
and
reflect.
2B?
No.
And do you know what the ventilation was in 6A between 26th of September and 9th of March 22?
No.
No, but you do know it's in 4B because
Yes.
and you do know what the ventilation is in the new 2A after March 22.
I believe that it is HEPA filtered for the bone marrow transplant service, and no,
So the reason I read this and is that we understand that after the 9th of March 22, 2A and 2B have 10 air changes, HEPA filtration, and 2A has a positive as a lobby, and they're highly fitted out, newly fitted ventilation system. In contrast with the period before, 6A is a standard ward, it's the same as 4C. And 2A, before the move in September 2018, outside its BMT rooms, was the same as 4C.
Right.
And the reason I say that is, in a sense, if quite a lot of these patients were in the same as 4C from 15 to 22, does that make one look at this chart in a different way? Whereas before then, they were in York Hill, which had HEPA filtration and positive pressures and airlocks and things. Does the knowledge of what's going on change the way you look at the chart?
No, I'm struggling to see it does. I mean, I would, looking at the data in front of me as it is there, I don't get a sense of there being a significant change over time with location. I mean, yes, we have got 2 years of 7 patients in total, for example, in 2017 and 2019, with individuals in different locations within the Queen Elizabeth University Hospital and Royal Hospital for Children's sites, whereas we had a maximum of 5 prior to the move. Does that indicate a problem? Does that indicate a true increase? This is where the analyses performed by Dr. Drumright perhaps give us some clues as to something.
We're going to go and look at that. I think that would be a useful thing to do. So if we go to Bundle 44, Volume 7, we'll just do it for the pediatrics. So we go to page 42, 44, 7, 42. Sorry, 44, 5, 42. We'll go back there in a bit. So that's Bundle 44, Volume 5, page 42. Yes, so I'm going to pass over the monthly counts table. I'm going to pass over a chart on the next page, which Dr. Drumright confirmed was actually mislabeled. This is BSI results. And if we keep going through this section, we will eventually, in fact, we go a bit further. We go all the way, we shouldn't have started here at all. We go to page 75. We go to the incidence of aspirillus rates in pediatric hepatooncology. And 5C.1, would that effectively be your chart, but now monthly?
I think so, yes.
Yeah.
Yes.
And then we go on the next page on page 76, 5C.2 is effectively your chart, but now it's got peaks.
Yes.
Yes, right. But the negative binomial regression is on the next page. And Dr. Drumwright's given evidence
Yes.
consistent with your comments. Now, I appreciate it was her analysis.
Yes.
What do you take, if we think back to the original purpose of your instructions, albeit that you don't have detailed knowledge of the ventilation systems that were in place, what do you take from figure 5C.3?
Well, I mean, what we're looking at here is what appears to be, over time, an increase, but it's at a very slow rate.
Right.
And the slope of the curve it's not flat. It is going up, but it's a very slow progression. So what does that mean clinically? We would speculate. My suspicion would be that if there is a genuine slow increase, that's probably related to factors, one, partly potentially occurring outside of the hospital. That's to say changes in Aspergillus epidemiology, which are well known to be occurring globally. It could be as well changes in the treatments delivered to children with hematological malignancies.
In that they are more vulnerable to Aspergillus.
Potentially more vulnerable, new drugs, new approaches, ability to treat sicker children, etc. So I suspect what we're seeing is a combination of factors rather than one specific factor. I would struggle to attribute that to a specific problem of the environment of the hospital.
Do you feel confident in getting involved in a disagreement between Dr. Drumwright and Mr. Mukherjee about the statistical significance of a change at the move of the hospital, or is that something you'd prefer to leave Dr. Drumwright?
I think Dr. Drumwright would be the best person for that, not myself.
Right.
Yes,
So what I want to do is to sort of go back to the conversation we had about risk just before the lunch break.
Yeah.
So we can take that chart off the screen. I was asking you about risk and safety, and you mentioned harm, and his lordship asked you about whether what we're looking at is eventuated risk. What? It seems a terrible question to ask you in front of his lordship, but what do you take to mean the idea of looking for eventuated risk? Risk that actually happen?
If I can just go backwards to, I think your original context of when you asked me that was, I think, Mr. McIntosh, how would I feel about a ventilation system in a new ward, a new hospital, not being validated?
It was, that's why I asked.
And patients going into that unit. What would be the risk, or how would I feel about that? Well, I'd be incredibly unhappy with that. But the reason being, I know nothing about this ventilated space. And I did mention at the time that the key thing I'd want to know is not the number of changes per hour and is not the positive pressure. It would be, is the HEPA filtration working? Is it actually keeping out particles? Is there any chance of contamination somewhere in the system, such that it's actually pushing in pathogens into the space, which would be a potential disaster? So that would be my main concern.
It's a precautionary response.
Yes. If there was clinical need, let's say the hospital the patients are coming from has got to close on
Monday because the electricals have gone. Yes.
So if that's, then it's a question of risk balance, and as we've discussed before, it's possible to mitigate the risks of the air handling unit not performing to the level that it should be according to specification. And as I've tried to really emphasize, I wouldn't be worrying about that excessively, since I'm aware of the limitations of the ventilation systems we have that are working properly.
To what extent would be the fact that you wouldn't worry? to that extent, is driven by the fact that the risk is acknowledged. You know what it is. It's been validated. It may not be what you want, but you then manage it as an acknowledged risk. To what extent is risk management about acknowledging a risk?
Yeah, absolutely. I mean, my problem with the scenario was I didn't know anything about.
Yes.
Yeah, it's just there, and we don't know anything about it.
And the reason we ask it is because the ventilation system of the hospital wasn't validated, and people didn't know that. So that's why we asked the question.
Okay.
So that's the reason we ask it. And I appreciate your answer. I'm grateful for it. I wonder if we can go back to the executive summary for the HAD report and just pick up some questions. It's on page 6 of volume 44, volume 1. Now, it was to explore paragraph 3. Now, we've been over a lot of these factors, and it may be we're diving in too deep, but we'll try. Okay. So infection risk is multifactorial and varies depending on microorganisms' ability to cause disease, pathogenicity, its natural habitat source, ability to spread, mode of transmission, susceptibility of the host to infection opportunity. What about the dose of the quantity of the microorganism that is in the environment? Is that a factor that we should think about in the multifactorial balance?
I'm going to defer that to Professor Hawkey, if you don't mind.
Because the reason I wanted to ask it relates back to the conversation we've just had about dilution. If you have a microorganism that's quite infectious, you don't need much of it, then a small dose, if that's the right word, one might think, and I'll check in with Professor Hawkey, might give rise to a risk. And so, could that be a reason why dilution is actually not an unimportant thing to consider? Even this is an area with lots of limited evidence. Or am I just on the edge of reason at this point?
I think we addressed this earlier, but I want to try and be consistent in my response to that, acknowledging that Professor Hawkey is probably a better opinion than me on this. But I feel we are asking a bit too much of the ventilation system with respect to when it comes to airborne pathogens. I don't think the question, we accept that ventilation systems, their role is there, even though the data is very limited. Once we start to go to non-airborne pathogens, in other words, environmental bacteria, then I feel this is stretching it a bit too far, but perhaps Professor Hawkey would be a much better opinion.
So I want now to return to a topic, take it off the screen, that I put to Dr. Drumright on, and you may have heard me do this. So did you read the Case Notes Review Overview Report, which is referred to in your document?
I did.
And so you'll be familiar with the idea that they conclude that 30% or thereabouts of infections are more likely than not to be environmentally related. And that's their conclusion from their exercise. And we can't see their workings, which affects the ability of the inquiry to use their material. But to what extent is their conclusion inconsistent with the view expressed in chapters 1 to 6 of the of this report, which is repeatedly stated that microorganism X or Y is generally not environmental? I mean, is there an overlap, is what I'm trying to say, between your positions as a trio and the CNR as a trio, that it's possible that up to 30% of the infections could be environment-related? Of course, 70% aren't. Are we actually arguing slightly at cross purposes here?
Yes, I think we probably are. I mean, the Case Notes Review, when I was reviewing it from the perspective of our work. in trying to answer the questions or the task given to us by the CLO. And we had an approach which was to establish rates of infection and have a comparator. So that was our approach. The case notes review clearly looked at individual cases over a particular period of time, which was much shorter than the period of time we looked at in our analysis, but in great detail. So their activity was completely different from our activity.
That they describe it as applying normal infection prevention control root cause analysis effectively.
I do not wish to disagree with that at all.
Right.
I'm just making the point that what they did was completely different from the exercise that we did. So perhaps attempting direct comparisons between their report and conclusions and ours is a slightly misguided exercise. But the point, at least for me, was that the exercise or the report of the case notes review wasn't providing context in terms of what's happened to that population of patients before and after the period that they identified there was an issue. And so I think what we're seeing in our data set is the problem they identified, because in the reviewed analyses, which I suspect we're going to come on to,
yes,
we can see there is something happening in the pediatric population, and there is an increase in bloodstream infections, which presumably marries in very nicely with the CNR report, because they found there were infections. The next step, which is, I think Dr. Drumwright's phrase was attributing potential causation, or what may be causing that increase, is where there is an issue.
Well, let's go and look at page 17 of Bundle 44, Volume 1, which is where you first comment on the CNR. Last paragraphs. A significant reliance appears to be in place on the Queen Elizabeth University Hospital CNR in relation to whether the built environment of the hospital pose an increased risk of infection. However, we do not consider the CNR as of assistance in determining this for reasons set out below. It's not quite what you just said, is it? You seem to have changed your position slightly.
Well, I think. Well, no, I don't. Have I? I don't think I have actually.
Because you described it as having validity and as potentially seeing the same feature, but from a different end of the process. They've come from individual cases, and they've seen an exceedance or something. And you, through your revised report, which we're about to come to, have seen something in the data as well. And there seems to be, you seemed very emollient about 2 minutes ago about their value and that sort of thing. And this is rather a different criticism.
I'm not sure I agree with that summary. So,
well, then, please correct me.
So the point I made, I thought, was that their attribution of approximately 1/3 of the cases that they reviewed as being attributable to the environment of the hospital, I wasn't really sure how they had done that, not least because, as you pointed out, don't have all of their workings. So it does make it rather difficult to, or impossible in fact, to comment on how they got to that conclusion.
Right. So you don't feel that, I mean, simply because you haven't got access to data, you can't really criticize their methodology in practical terms because you can't see what they did. Is that what you're saying?
Well, that's certainly a fairly profound problem, but also, and this is something I think Professor Hawkey will cover in much more detail, is the whole lack of confirmation, let's put it like that, maybe I'm not phrasing that appropriately, of the whole genome sequencing data that does exist to show, while there are, I think, at least 2 infections which by whole genome sequencing do show a link between the clinical infection in the patient and the environment. the remaining analyses haven't found that to be the case. In fact, have found that the clinical isolates that have been typed and environmental isolates that have been typed are all different.
Yeah.
So that's just one element of a number of arguments to just make me wonder on what basis did the case notes review seem to come to the conclusions that they did.
Because I suppose let's actually look at your recalculated data for the pediatrics. And I'm not expecting you to go into the statistical significance of what you see, or indeed the epidemiology. And Dr. Drumwright talked about the possible scenarios and counterfactuals, and she gave evidence of how you might think about it. I think she acknowledged she hadn't read the CNR, but she gave us thoughts about how to think about it. We go to bundle 44, volume 5, page 50. So if we take the top half of the page, this is the environmental BSI.
Yes. Okay.
And just to complete this, so you don't think I'm trying to hide it, if we go to page 51 rather, we go to the non-environmental. But let's go back to 50. I appreciate you're not an epidemiologist. So there's going to be a point, I suspect, when I ask a question in a moment and you say, that's not my field, I'll defer to Dr. Drumwright. But we'll try.
Yes.
So one of the first questions I asked her to consider that obviously water and ventilation were scenarios that were being posited, and a series of counterfactuals. And they included line care, single rooms, nursing. I think to some degree they became one counterfactual, but they were discussed. Antibiotic usage and the effect of that. She mentioned concerns that she had, admittedly, without looking at evidence about laboratory work and contamination, and then concerns about what might be termed as dysfunctional management at a very broad sense. Now, firstly, are there any counterfactuals you'd like to add to that list before we go any further?
Within use of antimicrobials, so just to emphasize the point, prophylaxis as well as use of antimicrobials outside of prophylaxis relevant, but also in terms of the workings of the department, specifically with respect to febrile neutropenia and its rapid treatment. So delays in rapid treatment of febrile neutropenia in the context of true infections can lead to negative outcomes.
Well, they would do, but would they lead to more infections? Since that's the measure we're looking at, not the outcome.
I understand that. The reason I mention that is I think, globally speaking, since this is such a frequent occurrence in hemato-oncology practice, febrile neutropenia, the management of that is key. So if you have practices that are not as optimal as they could be, and it's not that easy to deliver, because I've looked at this very carefully at our centre, delayed treatment is not just going to lead to poor outcomes in terms of potential death or morbidity, but probably more antibiotic use. So I'm just getting at the complexity.
Are you suggesting that a theoretical mechanism by which there could be more infections is that the management of neutropenia is not as optimal as it could be?
Yes.
Right. Yeah. I suspect that, Well, what I'll do is I'll still ask the questions I was planning to. So I'm going to see if you have any views on two extreme positions. So since we're looking at BSI, we'll look at water. So there are two extreme positions, and I'll put them both to you. The first is that all of the environmental infections seen on this chart in that peak above what's the linear component are caused by the water system, the contamination of it. And the second is that none of them are. And I wondered whether you would be supportive of keeping either of those in contention, or would you exclude them as possibilities?
Well, I'd exclude the second one straight away. I think it's inconceivable that no infections were caused by environmental organisms, some of which came from the water, I think. And also I think we know that from the the whole genome sequencing.
Well, there's been two.
There are two cases. So,
But to be fair, neither of them are in your data set.
quite possibly.
Yes.
But for the first proposition, I would exclude that as well, based on what we are looking at in the data. Because what I see here is that events, when the new hospital opens to the children, there's a downward trend that's already started before the hospital opens. So in other words, it started at York Hill and continues down, and then there's a change. And
Yes, I mean, Dr. John Wright's evidence was that I put two possible scenarios. One is there's a real downward trend that starts in early 14.
Yes.
And the other is that what we're actually seeing is the GAM model trying to smooth to fit the lots of zeros that you could see in late 15. Okay. And I think, to be fair to her, she wouldn't be drawn between the two.
Okay. Yes. Well,
but if you're, in a sense, excluding those two possibilities, I mean, I assume that one of the reasons you exclude the 100% is because some of these infections are going to be brought in on the patients because of the nature of the bacteria involved. Yes. If we go and look at the non-environmental infections over the page. So, Doc, for the non-environmental effects, what sort of counterfactuals did you have any knowledge about, other than what's covered in the letter of instruction, about the work of the CLABC group in the Schiehallion unit in 16 of 17 and 18 to address line safety issues?
Not at the time we did that work, although I do now.
I mean, it's mentioned in your letter of instruction.
Yes, but we didn't see that, I'm afraid.
Right. So if we apply a slightly more extreme position to more options to make it more confusing, will any of the non-environmental infections have any prospect of being caused by water? I think I know the answer, but I'm keen to see what it sounds an odd question. But can water have any role in this?
I have to defer to Professor Hawkey because I would like to say no, but I'm not sure that's the right answer.
What I'll take is I'd like to say no, but I prefer to Professor Hawkey as your answer. Yes. So if we look at the other candidates, for what have you read about the CLABC work since we instructed you?
It's mainly the report by Miss
Miss Roger. You read a statement by her?
Yes.
Some paragraphs from her statement?
Yes.
I think it's not a report.
That's what it is.
Yes,
it's in one of the bundles.
Yes. And then a presentation with some charts and
possibly,
a little bit of information.
Yes.
Do you see it's possible that work on the line safety being detrimental and then being addressed could form part of the causes of this peak?
Yes, given that this is non-environmental bloodstream infections, I would have thought it's likely that line care is one factor and is probably an important factor in this, yes.
If you go back to the previous page, I put this question to Dr. John Wright, and I think it's useful. I'm going to use the word sum to mean a non-trivial, relatively significant amount, but I'm not holding anyone to any more than that. If we think of all the counterfactuals and we think about the environmental pediatric BSI, now, of course, this is where you might say, no, I would prefer Dr. John Wright. But if we start with a contaminated laboratory sequence, is there any possibility that what we see here is consistent with some of those infections being caused by a laboratory problem?
For the environmentals,
yes,
I think that's unlikely.
Why do you say that?
Well, whereas I can see for the non-environmentals, contamination, be it in the laboratory or more likely in the time of blood culture, is
at the moment of taking the blood.
Yes, it's very probable. It certainly could apply to some environmentals. It could do, but it just strikes me as being less plausible. But it's not zero. So for some, is
So when we take the issue of management, I recognise you don't know anything about the management in this hospital. You've not really studied it, I'm assuming.
No.
Do you have any experience of hospitals with dysfunctional management.
I'd be surprised if most departments don't have an element of dysfunction, if
Indeed.
I'm frank.
And so I'm wondering, do you think a dysfunctional management would contribute to some degree to a peak like this?
That's an interesting question. I'd say yes.
And why would you say that?
The impact of the question here is that there are increased bloodstream infections, so serious problem in the paediatric population. Why might that be, and why might it be related to dysfunctional relationships? Because that's going to impact on the workings of the whole department. So it's not just the dysfunctional members, it's going to be, are people able to deliver the things that they say they're going to deliver? So for example, I just gave the example of rapidity of managing febrile neutropenia. Are they going to be able to do their line care in the way that they would like to do it?
Is the microbiologist going to talk to the infection control doctors, that sort of thing?
Yeah, what's the impact on staff morale? I mean, I can see many ways in which the performance of a department is going to go like this, and the impact of that will be seen in different places.
So the reason I ask this is because I know, and in fact you don't, but I know, and we've heard evidence about when the dysfunction started and how it went on, and we might form a view when it was worse and when it was better. To what extent would you expect things to get better after a department stopped being dysfunctional? This is the sort of change afterwards, the afterwards comparator.
I think if it's...
Or is this on the edge of...
I just feel, I can't say I've got any objective reply to this, it's subjective, is that it would take a little bit of time. I can't see how, if you've got significant dysfunction, which really means interpersonal relationships, and that's corrected, staff change, there's new leadership, it will take time for that to filter through to everyone who, to then sort of come up again.
Now, with the antibiotic use, antimicrobial use, I'll talk to Professor Hawkey in more detail, but am I right to think that we need to look at the actual microbes that are affected rather than a big class like environmental, or is it something that would see a signal in a big subset like environmental pediatric BSI in your work?
So antimicrobial use, antibiotic use, with the meropenem question,
yes,
then I think you already have that. So there is an increase, or there appears to be a high number of infections attributable to Stenomatotrophus multifilia. So if you want, there's evidence that says whatever drove it, could it be related to changes in antibiotic policy? So that's a possibility that is addressed by Professor Hawkey.
Oh, so we'll deal with that with him.
Yes.
Yeah. So we'd look at the connection between those things. Right.
Also, just to mention, if you have a change in antibiotic policy, and I'm not quite sure if the paediatric department had the change of antibiotic policy around this time, but it may have included introducing more antibiotics, such as prophylaxis, that they didn't do before. And I have to say, I'm not clear on that.
So what should I be asking Professor Hawkey to see if there is a temporal connection between these sort of behaviours and the data?
Yes, because the reason I mention that is if that was the case, you would see a decrease in bloodstream infections after introduction of something like prophylaxis that wasn't there before.
Right. Now we move to the water, because I'm going to pass over ventilation at this chapter. Remembering my definition of some, is what we see here consistent with some of the environmental pediatric BSI being connected to water?
Yeah, potentially, yes, absolutely. I mean,
why do you say that?
Well, because to me, it's inconceivable that the infections seen in this group of patients isn't a combination of different sources,
right?
Of which, in my opinion, and I think most of the literature supports this, the vast majority is endogenous. So in fact, translocation of
The vast majority, like 70%?
yes, if not more. I mean, some, but some in the context of a lot.
Yes.
Yes. And then the question of, well, have some of these infections been acquired from the potentially similar or the same organisms, but from the from the environment of the patient's room or elsewhere? Then yes, that's going to be the case in some cases.
Okay.
Yes. And I should say, as a normal part of the world that we live in. I mean, when I say that, I'm not suggesting it's because of failures. That's just, I think.
Well, you wouldn't know whether they're failures because you've not looked at the
Well,
sectors.
exactly, yes. There would have to be something unusual to make you investigate for failure.
Well, indeed, and I'm not going to ask you about the material you didn't look at, so that would be unhelpful. Now, final question. No, I think you've answered that. Well, I think probably I've answered all the questions I need to ask. We didn't do it quite in the order I planned, so whilst I'm asking my colleagues to see if they have any questions, I might take a moment to reflect to see if I've got everything.
Right. If Dr. Agrawal will bear with me, can I ask him to look at what is Bundle 44, Volume 5, page 117. It's your 18th of May 2021 report, Dr. Agrawal, and that will be put on the screen for you. Now, can I just go through this to see if I understand it? Now, I think you start with accepting, or being to put forward as a proposition, that the absence of any specialized protective ventilation on 4C, which is a neutropenic but not BMT ward, does give rise to a theoretical risk of increased airborne infection. So that's step one. You accept for the purpose of this section that there is an increase in risk associated with the absence of protection, in contrast with the protection that's provided in level 5 in BARTS.
If you're nodding and you meant to say yes, you need to say yes.
I was going to say yes.
Mr. McIntosh is more conscious of that than me.
Dr. Agrawal was going to say yes with a caveat.
With a caveat. So that's
right, yes with a caveat. Well, do you want to add the caveat at this point?
Yes. So the caveat is that the converse is not true. That's to say, with a compliance system, the patient is protected. It's just that they are less likely, so the risk is less. But the patients in our unit, in these facilities, do get airborne infections. So
yes, okay. My fault in using the word protection. If we take the word protection as including not total exclusion, not just total exclusion,
right,
but reduction in volume, quantity, whatever. Now, starting with that, you, because this is what you were asked to do in terms of your instructions, apply your mind to whether or not that accepted risk is material or not. Now, step one, what do you mean? What did you it's not your word, it's in your instructions. What did you understand the word material to mean?
I take that as two potential meanings from the way we perform the work. And so it would be fair to say that in terms of the airborne infections, which I focus on Aspergillus, that was my work. I take it one to mean that the risk is increased. So the risk itself. But the other way I've looked at the term material in this context is that risk manifest? I think I used a different word from your own earlier. So can we actually see that actually leads to material?
If I was to suggest a definition of material as makes a difference, would you accept that?
I'd accept makes a difference,
Right.
yes.
Now, you go through a series of factors which I think persuade you that the accepted risk does not make a difference. Now, why does the fact that a different risk, that's the overall risk of infection, is mitigated in other ways, make any difference to the materiality of the risk that you're considering in this section?
Yes. So I think the answer to that, Your Lordship, is in the word theoretical. So again, it's what do we mean by the words we use? So when I use theoretical, I'm accepting that having a ventilation system that meets the standards that we are discussing is supposed to, theoretically, deliver a safer environment for the patient from airborne pathogens. But what I haven't explained it here, but I reference the various sections of the report where I discuss why, the various reasons why it doesn't do that and why it fails to do that.
Well, I can see that one might take the view that the provision of protective ventilation, such as you have in BARTs, and which I imagine has been installed at great expense, makes no difference. I can understand that as a point of view. But that doesn't seem to be the premise which you have accepted for the purpose of 5.7. And the reason I'm emphasizing this is that we may have to consider the impact of your statement that accepting there is a risk, it's not a material risk. So going back, why does A make any difference to the risk which we appear to be discussing in 5.7?
So
it seems to me that what you're saying is, well, a different risk is mitigated in a number of ways, which may be true, but I don't see its logical connection with the exercise which we may understand you to be carrying out in 5.7.
So this, I think, is slightly controversial. And what I mean by that is that we have various guidelines saying that ventilation systems achieve a certain degree of this, if I use that word for a second, from airborne pathogens. However, as I've said before, there is very little evidence of that is the case in clinical practice or in studies.
If I may intervene, I understand you say that.
Okay.
It's just the exercise that you appear to be going through here, which is, even if there is a risk,
I see what. Okay.
It's not a material risk.
Okay. My apologies. I think I'm just
well, no, I'm
struggling
sure it's my failure to make myself clear. Because I don't quite see how factor A reduces a risk which you may have simply accepted for the sake of argument.
So I think for the purposes of the point you're making, Lord Brodie, I accept that if there is a risk associated with a non-compliant ventilation system, then any mitigation of that risk doesn't reduce the risk associated with that failed or inadequate ventilation system.
The no clear evidence point, which we've talked about, may be true, but doesn't mitigate the risk if you assume there is a risk.
So that comes back to where I feel slightly uncomfortable, although I've accepted your position, and hence my use of the word theoretical in my statement there. But no, that's fine. So I accept that.
Yeah.
I accept that.
I mean, this may seem very pedantic, but your report will be considered by lawyers, and lawyers tend to attach importance to, maybe undue importance to words. And similarly, C, how does that impact on a theoretical risk once it's accepted for the sake of argument? If we are looking at the situation of a patient who is in a neutropenic ward.
So the protection, the function of the ventilation system is to reduce the risk of particularly airborne pathogens. Clearly, if the individual cannot be in that room for any reason, then immediately the utility of that room, it's irrelevant, yes.
Right.
And that is a part of the normal care of individuals in these rooms. So it's another one of the limiting factors of what can be achieved with ventilation.
Yes, I see it as a limiting factor, but again, it doesn't seem to bear on the materiality of the risk that we appear to be looking at in 5.7.
So I accept your point because I've accepted it already at point A.
Well, right.
But the impression I get listening to the argumentation is that the risk is going up all the time because we keep on listing points, but it doesn't affect the risk.
Well,
but I'm not sure that's
rather
the case.
than unnecessarily take up time, can I put it to you that accepting all the points that you've made, if for the sake of argument, one attributes some value to protective ventilation, therefore the absence of protective ventilation can be described as introducing a risk. In fact, all the subparagraphs may be accepted as factually correct. None of them bear on the materiality of that risk.
I accept that, yes.
Right, thank you. Now, Mr. McIntosh, were you proposing to take a break to allow...
Well, I have one question which I realised I didn't ask.
Right.
So this was in the context, actually, a couple of pages back, page 109. Remember we got into a discussion about dilution in relation to paragraph 4.1.3 and airborne pathogens? What I didn't ask you was another question. And you've listed 3 sources of infection, so patients themselves, airborne pathogens, transmission to pathogen visitors. What about the hospital environment itself? So one might include in that building works or infestation of animals, or particularly building works seem to be a theme. Would that get chopped up and recompartmentalized into the other ones, or is it an additional possible source of infectious pathogens for this ward?
Oh, absolutely. No, I mean, the hospital environment itself is undoubtedly a potential source for these pathogens, yes.
And I'm trying now to remember where in London your hospital is, because...
It's right in the middle.
I realised that, but I was being more precise than that. But London's, in that sense, are homogeneously busy.
Next to the Old Bailey.
Thank you, exactly. Well, I know exactly where that is. So there's lots of traffic?
Yes, absolutely.
Wildlife, people.
Building works.
Building works. So does that influence where a hospital is, the importance or otherwise of HEPA filtration, air changes, these sort of things?
Building works, definitely. So that's very well documented in the literature. That major building works, usually in the precincts of the hospital concerned, is a risk factor for fungal infection. Well, fungal mold infections.
So do you do anything when building work starts near your hospital? Do you stop using the
no,
bays or anything like that?
No, we're using the bays
All the time.
Yeah, they're all the unit is constantly full, so it's not a choice. So if there was a major building works going on, let's say on the floor below, for
Yeah.
example, or on the same floor somewhere, then that risk would have to be mitigated by our colleagues in infection prevention and control to address the predictable impact of increased disturbance to the environment by the building works, principally high levels of spores, sort of supra levels of spores in the environment. So, and that could include something that we don't do routinely, the use of appropriate antifungal prophylaxis, for example. So that would be one approach to that.
One thing I wanted just to clarify, because I somehow got this in my head and I don't know if it's true, and I want to be sure. Your fifth floor, does it have any overarching ventilation treatment that distinguishes it from the rest of the hospital? Is it pressure differentiated from the rest of the hospital of the whole floor?
Not the whole floor.
No, not the whole floor.
No.
I must have misunderstood. Yeah, that concludes the questions I have, but there may be that colleagues in the room have questions. We might have a 10-minute break to allow that dealt with.
Dr. Agrawal, our procedure is to check if there's any questions which legal representatives wish asked. So if I can invite you to return to the witness room, which opens no more than 10 minutes.
Okay, thank you.
We stand.
Well, two questions.
Two questions, Mr. Macintosh.
Good afternoon again.
Two questions, I understand, Dr. Agrawal.
So the first question, I think, is merely factual. Since we've taken a lot of evidence from you about the nature of the ventilation system on your fifth floor at Barts,
Yes.
Is that fifth floor 100% mechanical ventilation? Or do you open the windows?
There are no opening windows in the hospital.
In the whole hospital?
Not that I'm aware of.
Not you're aware of, okay.
No.
The other question is this. So in the context of either BMT or hematology wards, so either 4B or 4C,
Yes.
or in your world, 5C and 5D, in this hypothetical situation, if a ventilation system on such a ward has not been validated against HTM or SHTM guidance, is that something that ought to form part of the patient consent process before procedures take place?
When you talk about patient consent process, what do you mean?
Well, what I mean, to help you, what I think I mean, so you can tell me if I'm wrong, Dr. Agrawal, is that I understand that when a patient has a procedure,
Yes.
they will be taken through a consent process which will inform them of the risks, the benefits, and such things. And depending on what it is, it may be a long or short process. That's what I mean. But if you want to use a different phrase, that's what I'm trying to get to. The idea where you obtain informed consent from a patient.
Yeah. So it's a hypothetical scenario. And I think the answer to that would be, it depends on what the consent is for. So if the consent is for the highest risk procedures one can imagine, so let's say myeloablative stem cell transplant, so intensive treatment prior to transplant, I think that individual should be referred to another hospital that has functioning systems.
Well, I'm not saying the systems aren't functioning, I'm just saying they're not validated.
Oh, we're not validated. But that comes back to the point we had before. So, I would need to know something.
Okay, I'll put the scenario to you. So, given that the hospital system, ventilation systems, were not validated, one can make the inference that at some point after it opened, adult BMT and hematology patients might well have been in an unvalidated ventilation space.
Right.
At that point, should they have been informed of the lack of validation? Or is it an implication that it's always validated?
I'm actually just hesitating because I think it's a very interesting question indeed. And I'm just struggling to collect my thoughts on it.
Before you finish, I add an extra fact, which I think you need to know. So at the time we're talking about, which I think in this case will be the 5 weeks, in the summer of 2015 in Ward 4B, and for some time, and I now can't remember how many years, but some time after the opening of Ward 4C, I don't think the treating clinicians knew the system was not validated,
right?
Albeit that neither did they check.
Right.
So in that context, can you assist us in whether they should have actively consented their patients?
So firstly, I wouldn't expect the clinicians to address the question, has this been validated? I mean, that would be an assumption.
Yes.
But that isn't the way most clinicians would be thinking, I don't think. You'd have to firstly make a decision, are we going to use the facility as is unvalidated? So you need to know. And once you know, then you would need to do a risk assessment. And if a risk assessment is rather like points where I was just discussing with Lord Brodie, then having attempted to mitigate risk, yes, that patient should be consented on the basis that the room that they're in, the environment that they're in, is not validated. The challenge I have with this is that we live in a world where that is generally regarded as the right thing to do. That's to inform an individual of the risks of any procedure. There is also, I mean, I also struggle to see how that necessarily helps the individual, as there's nothing they can do about it. They need a bone marrow transplant, they need a bone marrow transplant. So are we not just engendering increased anxiety, in fact, a severe degree of increased anxiety, plus with my position that there are effective ways of mitigating that risk. So the only proviso I have around this is knowing that the system is not making things worse, but we don't know that. So that would be my one big caveat. If I don't know the system is not making things worse, then I would have some, I wouldn't proceed with high-risk procedures in that environment. So I come back to what I said before. I would need to know something to convince me that there wasn't, there weren't aspergillus spores being pushed into the space. I would need some reassurance. But if I had that reassurance, then I think consent would be
So would you need, if there was information about
spore counts, for
spore
example.
counts?
Yes, for example. Yes.
That would inform that process?
Yes.
And do I get the impression from what you're saying that if you discovered that there were spore counts in an unvalidated system, your reaction is not to consent the patient, but to send them somewhere else?
Yes, if
in the most vulnerable cases,
we're actually causing harm. Yes.
Yeah.
Yes.
I think I.
Could I just explore what might be a consequence of that? I understand what, or at least I think I understand what you said about the practicalities about consent, but you started that section by recognizing the ethical obligation of any clinician to obtain consent certainly for a procedure,
Yes.
but possibly for placing the patient in a particular location. You said, and it seems to me entirely reasonably, that a clinician moving into a new facility would assume that the facility is as you would expect the facility to be, and that had been confirmed by, in the case of ventilation, validation.
Yes. And
you couldn't blame a clinician who didn't assume otherwise. Now, does that have the consequence that there is an obligation on those managing the facility to ensure that there has been validation in order to, as it were, support the clinician who assumes that the facility has been validated?
Yes. I need to just caveat one thing I just said, and that is, it would not be, the clinical team would not be without any information, because the whole JC process, we talked about JC earlier, very much addresses these issues as well. And so there would be a director of the facility who would be the JC representative in that facility. And it would be their role to know this information.
Whether there'd been a validation?
Yes. Yes.
And is that been JC policy for a long time, or is that an innovation in recent years?
Well, JC doesn't mandate that you need such a facility in the first place. So we come back.
Well, that's what I mean, because since I know that,
yes, but
how does a JC director acquire a duty to find out if something they're not required to have is validated?
So we have this apparent dichotomy that the regulatory standards don't mandate this level of protection. And yet, clinically, it's what all bone marrow transplant centres have in the UK, as far as I'm aware. So if you have such a facility, then it should meet the standards that the specifications require, that the regulations require. And hence, I would expect the director to be aware of these things before it was commissioned and opened, yes.
Thank you. Thank you, Lord.
And thank you, Dr. Agrawal. You have given evidence over what's been quite a long day, and thank you for that. And thank you also for the great deal of preparatory work that you have put in order to prepare for giving that evidence. So you're free to go, but you go with my thanks. Thank you very much.
That's very kind. Thank you, Lord Brodie. And so thank you, Mr. McIntyre.
We stand.
But before we stand,
Yes.
Tuesday morning, my lord, 10 o'clock, Mr. Mukherjee.
Right. Well, thank you to the legal representatives, and we will see each other again on Tuesday morning at 10, and have a good weekend until then. Thank you.